comes the heart palpitations. So I'm very bad at the sort of, and I noticed in my analysis, it only took me 9 years, that it's a way to dilute my own convictions or voice to stand
Yeah.
behind my own beliefs. And so I go sort of this or sort of that, and we're all self-depriving, masochistic, depressive, blah blah blah. It's in this type of work. This is wonderful practice. So thank you again. That I'm doing the introduction yet, but thank you again for humoring me with all this. It means a lot that you're gambling on me and gambling on this project.
It's no gamble with you, Max. we just know it will go well. But you and I know it's not a gamble.
All right, so welcome back, Dr. Christian, if I can call you that. Today we are here for episode number 4 of What the Fuck is Life, but episode number 2 with yours truly. And today we're speaking to something quite controversial, I hope, to get those eyeballs and ears from the audience.
We're talking about trauma.
What is trauma? I don't even know anymore.
See, when you say what the fuck, but do you ever do it WTF?
Yes. So like I said, when we first met, I have to edit out, from what I was told, the WTF is okay in the beginning, and then you could pick and choose in a very selective and purposeful way how often you swear. Otherwise, the YouTube algorithm doesn't like it. So WTF works too, but also what the fuck, and also fuck you too, because I'm not monetized anyway.
Mm-hmm. F you too.
F you too. at two, brute, and then you stab me. So I'm excited though. Today we are speaking to dramatic, drum roll, that trauma is a controversial topic nowadays. It doesn't seem to have an agreed upon definition. It doesn't seem it seems to transcend all types of therapy. And I'm not sure I even know what it is anymore. If we can maybe start there with what you want to do.
I was thinking about that. I knew we were supposed to talk about trauma today, and I was thinking about what it is. I don't know. I mean, there's a lot we can say about it, but it's become less clear, I think, what trauma is. We could get in trouble in this conversation.
Well, absolutely. By the way, my microphone was on the other side of my desk, so I'm not even sure if so far this is going great. I'm not even sure if you could hear me.
Yes, these technical difficulties are.
Yeah, this is wonderful.
Yes.
Can we do it? Are we far enough into this project that we can do a blooper reel at the end of it?
Yeah, I think so. I think even though we only have like an hour, maybe half of it is bloopers already.
Okay.
So I think we're okay.
But yeah, trauma is a hot topic.
It really is. And one of the first things I wanted to say or ask you about is it certainly does seem like the word trauma has gained in how much it's used, right? It's becoming used in more and more expansive ways.
Certainly.
And I think there's one way in which that doesn't bother me, partly because it's the kind of thing that you can't do anything about. And it might be kind of mixed good and bad, is that a lot of psych terms, Freudian terms over the decades and other terms too, they just kind of ooze out into the public, into ordinary language use and get used in ways that are lighter. Like, the examples like OCD, in order to refer to just neatness. Like somebody will be kind of quite particular or fastidious or neat. And
they
someone
say
will
it's
say,
anal.
Yeah, it's anal retentive, or you're so OCD, or that kind of thing. And I think that's unavoidable. And I think not particularly problematic, or if it is problematic, there's nothing anybody can do about it.
Language evolves.
And so it can be, as a clinician or as somebody, when someone has suffered trauma, I think it can be upsetting to hear like, oh my goodness, this thing that matters to me so much is being used lightly by other people. And I suppose that can be upsetting, but again, it's not much people can do about it. But I don't know. I wondered what you thought about this.
Yeah, I mean, in preparation for this robust dialogue that we're having today and resolving the problem of language being descriptivist or prescriptivist, I have Noam Chomsky joining us later. It'll be very interesting. I agree with you that, first of all, I've never heard somebody say it as politely as you have. So kudos to you. Nobody in my nobody in my personal or professional life has said somebody's using the word trauma too lightly. More, it's like, I'm traumatized, you're traumatized, you're trauma informed, presumably, or by implication or some law of association or something like that. You're trauma misinformed or malinformed or uninformed. And it's been used as this, sword and shield. It's been used as this veil against, ironically, a deeper understanding, and probably we have consensus here, and appreciation for what trauma, capital T, is. In fact, that just came to mind because I had an instructor somewhere in grad school or in my institute training that used, I forget who it was, but used uppercase and lowercase t to qualify the types of trauma, because there is if you were to start somewhere in a good faith discussion about this, which I hope we're doing today, there is such a thing as trauma. There are traumatic events that are, certainly qualify as a capital T: overt violence, overt abuse, overt pain and suffering, overt loss. Those all, in my understanding, qualify as trauma. The difficulty or the trouble being, of course, is the dilution of the word, the proliferation of the word, and the maybe inadvertent consequences that have led us to this place of where you have to quote unquote be trauma informed. Maybe we could start there, and as if there are people that are trauma, again, jokes aside, misinformed, or not appreciating the value, the significance, the robustness, the causality behind it.
Yeah, I mean, I think any competent psychotherapist is trauma informed, because
Right, exactly.
if you have a psychotherapy practice and see, just select patients randomly, even if your patient population is, people who can pay a fee and who have a job, who are very, very functional, you're still going to see like a lot of patients with trauma. It's just unavoidable. The only way to avoid having patients who have trauma in a clinical practice, I think, would be to see a very niche kind of clientele, like people who maybe just have phobias, small phobias or something. But for the rest of us, I think you're going to see trauma.
I'm compelled to interrupt and say, I don't know. Is this a controversial hot take alert? Is it spicy to say that everybody has experienced trauma in the spectrum? Is that not the again, I don't really stand strongly. I'm not putting a flag in that hill saying that's true, as much as I'm saying it feels like so much of the human experience involves suffering, as we understand pathos and pain and the ontogenics behind it. Is it fair? And maybe it's not, again, to not to
Yeah.
say it, but it certainly feels like growing up involves certain traumas, or losing loved ones, which we all go through, involves certain traumas. Is that part of the problem of that I'm diluting? Sincerely, I don't mean to, but is that diluting the word clinically or colloquially?
I think it could be. Yeah. I think I would take the no answer. Not everyone has
Okay.
experienced trauma.
I guess then you have to leave this podcast.
Goodbye. But I also think, depending on how you use the word, so it is ultimately a question of semantics.
Right.
There's a yes answer that's not absurd or awful or crazy, that in fact would make a lot of sense too. So I suppose we should talk. Oh my God, we're going to have to do this next. We should talk a little bit about trying to define trauma before we figure out any of these difficult
It's
questions.
going to take up the rest of the hour.
And it's going to get boring and
Yeah, we're
academic.
fucked. Yeah, yeah,
Criterion one of trauma.
yeah,
Um,
yeah. We're screwed.
I,
But this, I do think it's important because it's not agreed upon yet to see. I don't, to bring up the Oxford Dictionary definition. Maybe that helps. Maybe it doesn't. But the clinical definition, or the DSM definition, versus the PDM versus the colloquial one, it's really challenging to figure out. So
we
wait,
should
so I
talk a
got,
little.
so but as
Yeah.
you continue, I got the definition during our technical difficulties. Dictionary definition is different. The noun is different than, of course, the medical or psychological, but it says deeply distressing or disturbing experience. In medicine, a trauma, of course, is a physical injury. And then in psychology, it says the psychological trauma is an emotional response caused by severe distressing events, such as bodily injury, sexual violence, or other threats to life of the subject or their loved ones. There's such a thing also as indirect trauma.
Yeah, so maybe we could distinguish different uses of the word. I think there's an ordinary language use of the word trauma, similar to the ordinary language use of the word depressed. Like, I ask a buddy, how was work today? And he's like, oh, I'm so depressed. I think we could say that that's ordinary language use. We know what he means. Or he says, oh, I had a hard day today. I was so traumatized. But really what happened was his boss was slightly mad with him and he's a little upset about it. I think the ordinary language use that's very broad, you can't say it's wrong because words enter the language the way that they do, but it's a very broad use. You'd want to ask, really traumatized, depressed, what do you mean? I think the clinical use has to be narrower than that, than just something difficult. In the physical clinical use, I guess trauma can be anything, like a slight injury that causes a bruise is a trauma. But I think in the clinical use of the word trauma has to be more severe than that. Otherwise, it doesn't have much clinical use. Like, every time a patient is talking about something quite difficult or moderately difficult, they'd be talking about a trauma, and then the word trauma doesn't really mark off some interesting and important phenomena that needs to be considered separately. So whether you call that big T trauma or clinical trauma, or you qualify it, real trauma or something, I do think there is some use of the word trauma that's actually quite narrow, that only occurs to some people some of the time in these more extreme circumstances. But I don't know. What do you think? Yeah.
No, I think I would agree. As the qualifier, dare I say, qualifies, and there's something important, especially in today's lexicon, vernacular, what have you, to qualify, because there is a colloquial, lighter definition, and then I don't think that it's necessarily harming or diluting if we can tolerate the reality that a qualifier is needed. So you could say I was traumatized by today. Today was full of trauma at work, and they were just speaking to interpersonal difficulties or stress at the job, versus acute trauma, like you said, or clinical trauma, or psychological trauma with a capital T, sexual trauma, emotional trauma, physical trauma. I guess I sympathize at the same time with the frustration that having to qualify it seems like a burden, maybe, versus somebody who could be up in arms and frustrated that they want respect, reverence, dignification, validation, whatever it might be,
Yeah.
for what they've gone through.
Well, this is what I talked about trouble. I mean, I also don't want to hurt someone or offend someone by saying, oh, you think what you have is trauma, or what you went through is trauma, but it's not really, because it doesn't fit this criteria
Criteria,
I'm about to
right?
give for clinical trauma. It doesn't fit the DSM-5 criteria or something. Like, I don't I don't want to do that. I mean, if something feels traumatic to you and that word seems to fit, then there's a use of that word, not necessarily even a light use of the word. It could just mean something really awful happened to you and it changed you and affected you. That's a use of the word. And in that sense, I think you're right that most every life would experience some of that kind of trauma, something really awful that does change you over
Sure.
time. That's another use of the word trauma. That's not just a light, ordinary language use. That's connected to clinical use. But I think it's kind of a bit vague and undefined. Like, how bad does it have to be? Does it, how much does it have to change you for it to be trauma in this sense of the word?
So is that so? Let me ask you, for the sake of time today and pending further technical difficulties, bloopers, and stomach aches, um, is there a motivation in particular, or an animating force behind you, insofar as what brings you here to speak to this? Because we certainly can be seduced into the semantic debate or the syntactical debate. On the front of my mind, to embarrass myself and maybe you or all of us or the 15 listeners again, is the colorless green idea. And having that debate, is their meaning without grammar and vice versa. Excuse me, without grammar and vice versa. And I do struggle with it, with our definitions. How do they work in the world of clinical, dynamic, and alive, maybe treatment or orientations or practice?
Yeah, I think we have to remember that words are tools, and they're tools, whether they're ordinary language tools or clinical tools or scientific tools or research tools. Words are tools that help us interact with each other to perform work in the real world. And I think it's useful to remember that there's a kind of narrow use of the word trauma that was important all the way back to Freud, and even before Freud, Charcot, that I think describes a phenomena that we still see today. And I think it's important to have a way of referring to that phenomena and distinguishing it from other phenomena that may be related, that may be also very bad things, in the way that the original kind of thing that was named by the term trauma is a very problematic and pathological thing. So, the original notion of trauma, I think, is that it's not just that there's a terrible event that happens, but there's an event or series of events that happens to you that are so intense, your capacity to think about them, categorize them, understand them, even almost perceive the events in some ways, is overwhelmed. The events are not just bad, like the death of a loved one, or finding out that a war is starting, or realizing that you have cancer. All of those are awful things, right? but there's something about the nature of the event and your capacity to kind of think about and perceive and understand and digest, we could even say, what's happening to you that gets overwhelmed. That's part one of something that's traumatic. And so then we also think children are more susceptible to this sort of trauma because their capacity to think about and understand and manage themselves is lesser than ours. And then I think the second part of the definition that, or the phenomena that Freud and Charcot and others were interested in, is after the event, there's a period of, I think they sometimes call it incubation, where you can see that the person is affected by the event. They're not the same, but it's also that they may be not thinking about the event very much. They may be trying to avoid thinking about it. And they may, in some sense, look like they've gone back to normal to some degree on the outside. This is some kind of period of incubation. And then there's a symptom period where all of a sudden these symptoms of trauma that we're kind of familiar with start to come onto the scene. We see flashbacks, nightmare, association, just a sense of the event which happened a long time ago has now caused the person to be unable to think and feel and just be themselves in all sorts of circumstances that trigger their symptoms. And I think you can't say that for every bad set of events. I mean, if you have a parent who's quite critical of you and really wants you to do your homework and pours pressure on you, maybe it felt awful, you were angry, you were annoyed, but you weren't able to be rebellious against them. It may result in your character, your personality having problems in the future. But you were never overwhelmed. There wasn't a period of incubation. And you're not now facing these moments where you dissociate, where your mind seems to dissolve, where an anxiety settles over you that doesn't even have an object. So I think this narrower kind of trauma, I think, is something that we need to have a word for, whether we call it capital T trauma or clinical trauma or something. And I'm not so concerned about policing other uses of the word trauma as I am remembering that we need some way of talking about this very specific thing called trauma, or that was once called trauma.
Right. If we don't, obviously there's a lot there. If we don't have a word, a concept, then we certainly can't talk about it, number one. So there is a requirement here. And then, like you said, number two, there are qualifiers or thresholds or some spaces that have to be, even criteria maybe, that have to be met, not in a strict, like you said, prescriptivist way that in service of policing or gatekeeping, but rather in service of helping. What is mobilizing us today and let's have this conversation? It's more in reverence for the reality, for that trauma exists, and less so to do with the moralization or politicking about or the debates of PTSD or trauma. I think that, as you said, in my experience with patients, clinical experience, training experience, my own treatment experience, or even my own personal history, the reality is there is a meaningful, capital M, meaningful distinction between a trauma that engenders or necessitates or causes or gives rise to dissociation, derealization, depersonalization, and so on, versus one that can be, maybe the word is integrated. And the contingencies seem to be, of course, the psychological anatomy, environment, upbringing, your genetic load, epigenetic load, the list goes on, all these sort of overdetermined multivariate causes, blah, blah, blah. But nonetheless, it's important, vitally important, that we understand that. I think something certainly can cite contemporary studies where people can bear witness to the same traumas of modern war, but only some people demonstrate or illustrate the symptomatology to do with PTSD. How is that? Why is that? So on and so forth. Well, it's all the variables that we struggle to tolerate because it's overdetermined and it's multivariate and so on. And that appreciation maybe is something that isn't really spoken to enough or agreed upon enough because of, like we talked about, the ways that our people are co-opting or bastardizing or polluting, diluting what's
Yeah,
actually going on.
yeah, it's resulted in a great clinical and societal confusion, I think, over
Yeah,
how
it's a
to
good way to
talk
put it.
about the word trauma. And my way of trying to navigate through the confusion is to say, look, you can use the word trauma as a synonym for horribly awful, and horribly awful to the extent that it changed me. But we as clinicians need to know that there are some things that are horribly awful that do result in a change to a person's personality that can cause long-term psychological problems that are different from the original idea of trauma, that don't cause dissociation, that don't cause a kind of breakdown in a person's ability to understand what's happening or to be able to think.
There's a
Yeah,
real, yeah, you're making to parlay with more into more metaphors or alongside more metaphors. The word metabolism comes to mind, right? Where
yes.
in how PTSD is understood or at least studied earnestly or modestly is of course the inability to metabolize the experience, the memory, and the stuckness, of course, as we've spoken to before, of an explicit memory repeating itself, or there's regurgitation, there's constipation, psychically speaking, and that stuckness, rigorous and corrosive stuckness, eats at somebody, and the information that has causal power is stuck, is arrested, and is generating further, it's pathogenic, it's generating further suffering. And that's a meaningful distinction in my eyes, in my clinical experience as well, in demarcating this for somebody. If it's really alive, causing problems, causing suffering, even if it was 10 years ago or 10 days ago, it hasn't been, to speak very plainly, brought within the psyche.
It hasn't been digested or metabolized. Yeah. Here, I know a lot of people think the work of Bion is a bit hard to understand.
It sure is. Oh, I lost you again. You're back.
The work of Bion, I think, is relevant here. And I know he's difficult to understand and quite abstract. But
He
Bion
sure
has
is. I'll make the joke again.
he has this notion of alpha function, which I think is useful. So when Bion is writing, he's aware that most people following Freud tend to think of all psychological problems as being associated with something that's unconscious, something that's in the mind but part of the unconscious that needs to be made conscious, right? You need to become aware of something inside of you, like a conflict or a desire, and as you become aware of it, you gain control over it. And there are problems like that. But for Bion, and it's interesting to note that Bion was a tank commander during World War I, and his whole unit was
I
wiped
didn't know
out.
that. Wow.
He then was working with soldiers during World War II, right, suffering what would have been called shell shock, which is the term developed in World War I. And Bion, and I can only imagine commanding a tank in World War I must have been just a brutal experience. But the notion of alpha function is that you can generate images, thoughts, symbols that can be used to contain something in the mind he calls a beta element. And a beta element is just kind of raw affect, as near as I can tell. I mean, maybe I'm oversimplifying. People might be mad at me. Not that that's scary to me, that the Beyond people will come after me. Uh, so
I'll
you,
write a very strongly worded, unintelligible letter, and you'll have to suffer
yeah,
through that.
read by 3 or 4 people. Yeah,
Right, exactly. The entire audience to this podcast.
but the beta element is, it's got raw affect and it draws all of your conscious attention. When you experience a beta element, you can't really put words to what you're feeling, or you can't put it into symbols or imagery. But as it's sitting there lodged in your mind, it's like it can't go into the unconscious. It draws all of your attention. It's only when you can take the element and put it into some kind of symbolic form or image form, a little daydream or some words that you spoke to somebody, that you can then put it into the unconscious, do something with it, think thoughts, arrange your thoughts. But beta elements, which are kind of raw affect, hit the mind, and the way Bion says it is, you can't make them unconscious. And in fact, in a way, you can't go to sleep. You can't dream.
Yeah, which is so true. It's really uncanny. Again, part of me wants to apologize for interrupting. Part of me really wants to jump in, so whatever, I'll
Jump in.
negotiate. I'll negotiate
Yes.
my own beta elements right now and convert them into alpha function. It's a great Prince album, by the way. The chef, making myself laugh. It's uncanny how accurate these people were, meaning beyond Freud, their contemporaries, etc., Jung, and so on. That in the world of, I always cite this, and sometimes I get self-conscious because it's my bread and butter at this point. But you know what I'm going to say: the neuropsych stuff now, the Soames, the Friston, the Turnbull, the Damasio, Panksepp. It's just uncanny how accurate that what Beyond is saying was. I mean, we now know this, and it's substantiated with the finest detail of our instruments, an fMRI machine, a PET scan, et cetera, and then substantiated again phenomenologically. And then the self-report maps onto oxygenation or the oxygen use of these areas of the brain without getting lost in, what is it, the function? I forget. Oh my God. Voxel-based functions. Is to say that it can't be, like you said, digested. It can't be metabolized. And so, of course, you repeat the dream. Of course, you repeat the trauma. Of course, it's stuck. Of course, it's not integrated. Of course, it's skipping in areas of from short-term to long-term memory and perverting that process or subverting that process. And these people are left, and again, in the robust definition we're speaking to, clinically or acutely, with incredible pain and suffering
Yes.
because, in essence, the brain processor system was hijacked
That's
by
right.
the nature of these stress responses that overwhelmed might even be a good word, the normal function of that ability to render it into something symbolic, to render it into something that can be metabolized, to render it into something that can be reflected upon or theory of mind used. Again, I think of integrated information theory. I think of global workspace theory. I think of any debates about where consciousness comes from. And they were speaking to this 120 years ago, before it was brought about. Depending on the theory of what gives rise to consciousness or where it comes from, outside of panpsychism, we're not going to go there today. It's uncanny how accurate Bion was, or other people, in speaking to how does this happen and how does somebody unstick themselves,
Yeah.
essentially.
Not just accurate, but I think clinically useful, and in a way useful for just ordinary people to have some awareness of. Because Bion says if you've got these beta elements that have an extreme quality to them, it'll feel like something is overwhelming your conscious awareness, but you can't really put it into words. You can't really, do some thinking and daydreaming and have it be something that you can move past. It's kind of something you have to expel. And he says there's various strategies people take for expelling beta elements if they can't put them into kind of alpha function, into imagery and symbols. You might get drunk and anesthetize yourself.
I
And
was
this
just
is,
going
of
to say,
course, a
right.
common thing, right? Or you might get
So
into a screaming match.
these would be
Yeah,
neurotic solutions to the problem as opposed to resolutions
that's
internally.
right. That's right. And this is what we see. I mean, one of the reasons, in the mid-century for having the PTSD diagnosis was there was a lot of patients coming in where they would have been given a diagnosis of like alcohol use disorder, alcoholism, or a personality disorder, or even psychosis. But it's because the solutions that they were deploying to get rid of these raw affects that were unmetabolizable, these beta elements, looked like substance use disorder, or they are, I suppose, or they looked like personality disorder, or they looked like psychosis, but they're not, right? And I think to understand some of the ways that the mind goes wrong, you need to understand this specific phenomena of how your ability to think and understand can be overwhelmed by extreme affect. And that's why I think it's useful to have a word called trauma that refers to this specific clinical problem or human problem, not to just a larger problem of bad and awful things. Because you can hear about bad, awful things and not have it overwhelm your capacities. There are people who live in a war zone and it's terrible for them, but they manage to sort of hear the news and grieve and feel anger and talk. And there may be moments of overwhelm, but then they recover their mind. I think trauma and PTSD are cases where the overwhelm is so great and the mind can't keep up. And I just think it's useful to have some way of referring to that specifically.
No, it is, and it's necessary and useful, as you're saying. It's we can't. It's ironic in the sense that the mind is hijacked, co-opted, polluted, or your agency is robbed from you. At the same time, the word itself or the concept has been hijacked, co-opted, and robbed. In the vernacular by it being proliferated, or its use cases just being prodigious and unending in ways that are almost it's like the well-intended person is building the road to hell by doing so. And it is a real phenomenon, a real disease, a real ailment, a real point of suffering. And yet there are people on, so to speak, on one side that are using it too casually, maybe, and then there's people on the other side that are saying it doesn't exist. As far as I understand, it's both are doing a great disservice to the reality that the overwhelm, like you said, the raw affect totally consumes or subsumes somebody's ability to function. And this again is in the brain and the mind, or in the heart and soul, in the spirit, all of the above. However you want to demarcate, these vertical splits of a person. But if you cannot organize or focus your attention in a way that's aligned with your own willful intent or intentionality, you're robbing yourself of what makes you human. Or the trauma is, not you yourself. And that is really, I do agree with you in the sense that that's lost on clinicians or lay people alike in terms of the severity and depth. Something maybe not being glib or flippant, but it's like someone who's you smoke too much pot, and you're paranoid as hell. And then somebody says, "Oh, calm down." I'm not speaking from experience. I have no idea what that's like. And I was not 15 when this happened.
Yes, it happened to
There was nothing
Smacks,
you
not
could. You could.
Max.
There's
Yeah.
nothing. Yeah, it happened to Zam. XAM, a friend of mine, just my best friend growing up, Bizarro Max, and you could talk to me till you're blue in the face, as they say. There was nothing. My affect, my beta elements, man, they're pouring out of my ears. I was fucked. I was, and there were it presumably was hours. It could have been 7 minutes. I was so high. I mean, Max was so. I mean, Zam was so high, but there was nothing you could do. There was
Yeah.
nothing you could do. And
Yeah.
and it's a great example. I think we've all experienced in various ways of anesthetizing, narcotizing, et cetera, that we've gone through, or polluting our own conscious experience, or hijacking it, or altering our state of consciousness in service of whatever developmental, constructive, and or neurotic force or form. We know what that's like intuitively. And yet when it's something as real and substantial as a trauma, we start to get debatey.
Yeah, and it's unfortunate. I don't, and I just want to reemphasize that I don't think it's ordinary people or patients or people who feel like what happened to them was trauma, or they want to use the word more broadly than I do. I don't think they're doing anything wrong. I do worry though, and I can't give you clear examples of this, I guess, but I do worry that there's a confusion amongst clinicians now about the concept of trauma that is more troubling, about how broadly to draw the boundaries. And I think a move away from linking the word trauma to the concept I was describing, that has to do with an overwhelm of capacities and inability to digest and metabolize.
For the sake of time today, can we speak to, given what you just said, what trauma informed means? Because that cultural thing, whatever phenomenon that's really taken off in my experience on listservs, attending conferences, lectures, instructors, training, institutes, university level, all of it, it seems to be very popular. So I am super curious about your take on that in respect, or even, dare I say, disrespect to the
My
phenomenon you're
goodness,
speaking to.
my take will get me in trouble.
Okay, so we'll be diplomatic, we'll be euphemistic. Again, there's only 4 people listening. And also, for the record, I wasn't talking about myself and I was speaking to smoking weed.
The only reason I said that is because, social media sometimes there's all these debates that get kind of heated. So maybe
Sure.
actually, so what I think is not that controversial in a way. So a couple of things. One, there is a good use of the word trauma informed, which is, if you go to a doctor's office, like a primary care doctor, they might say like, actually, I'm trauma informed. And what that means is they've done some psychological training about trauma, so that if you want a primary care doctor and you really have been talking with your psychotherapist about how you're traumatized, I mean, they might be able to help with that. If you've been through sexual trauma, going to the doctor is a very physical encounter. Having a trauma-informed primary care doctor, that makes sense. That's useful. The word, though, becomes more confusing, I think, when we talk about psychotherapy, because I don't know what it would mean to be a psychotherapist who isn't trauma informed.
Right. That's the show. And again, is that a semantic debate or not? To me, it's meaningful. It's not just semantics because I don't say I'm trauma informed as a psychoanalyst. To me, it's implicit to my training or intrinsic to it.
Yeah. I think here's what I think the word trauma informed means. And I'm not trying to straw person or straw man the debate so that I can like score a point against it. I think the idea is following a number of authors who, like Gabor Mate and Bessel van der Kolk. There's a set of ideas about what trauma is that are not far off of the truth. That they're kind of fit with what we're talking about. Although I think they broaden the notion of trauma. Mate seems to think a lot of things are trauma. But they think the way to deal with trauma is to perform certain kinds of interventions that are very much like EMDR or interventions that are kind of manualized therapy, and which they'll claim are scientifically known to be more effective than just kind of regular psychotherapy that's with a talented, skilled clinician who forms a connection with you. So I think the idea behind trauma-informed therapy is not that they're more informed. That's the misleading part. Because I think they know that we all learn about trauma and we all read about it. And we all have cases of people with serious trauma. If you have any kind of clinical practice, you're going to encounter some cases of people with very serious clinical trauma.
Sure.
I think that the trauma-informed people think their techniques work better than psychodynamic psychotherapy, exploratory therapy, depth therapy, that these kind of manualized things, and then you could list what they are. I think EMDR is at the core of a lot of them. That's how you should treat trauma. I think that's what the trauma-informed movement means. And the rest of it is kind of a little bit of rhetoric trying to get the public to see what they believe, which is that we're the only ones who know how to treat trauma. That you and me, Max, because we don't do those techniques. It's not that we're not trauma informed, it's that we're not able to treat trauma. I think that's the implication.
And again, your interpretation is generous. I mean, the first example of experiencing a primary care physician of whatever kind, whatever specialty, and them saying they are trauma informed is something I've never experienced personally, which, what is that, an N of one? But I've also never heard a patient or a student or supervisee or an instructor or supervisor of my own ever say that. I agree with you. That seems very responsible. That seems very
It's something
considerate
you
and
could do.
empathic.
Yeah. Yeah.
Right.
I've heard one
Other
case of it. Yeah.
other stuff that you speak to, the other examples is more my exposure. Again, I don't particularly feel like I have a flag to put into the hill or to die on this hill. But yes, it seems to be a marketing thing. If that's, I don't know if that's too spicy a take. It seems to be implied that there are trauma uninformed. I understand that that's not the impetus behind it, but it does imply that then, like you said, I cannot treat it, or I'm not equipped, or I don't know. And then, like you said, the veiling, as we all can be guilty of and struggle with the dodo bird verdict and iatrogenic variables and confounding variables, and the control being no psychotherapy at all. As we've talked about many times, replication crisis, or at least people should know that in the field. So we say, oh, well, EMDR is scientifically proven, right? It's the gold standard, and every other thing isn't, or whatever. I'm not sure if there's other. EMDR is the one I'm also familiar with for trauma or complex PTSD. And again, it's not to say it doesn't work. It's not to say I'm not trained in it. Maybe I'd be pleasantly surprised or informed, but it is to say what is missing, or what am I missing, or what are you implying, or what is the claim that trauma has to be intervened with in a very acute and very specific way that, as you said, regular old psychotherapy can't provide.
Yeah. I think that's the claim. And I just disagree with the claim. And I disagree with this claim on kind of neuroscientific grounds. I disagree with it on empirical grounds. I don't think there's any strong case that EMDR is somehow well known to be more successful than other forms of therapy. And just on clinical grounds, my own experience. I mean, what we know based on the definition we're giving is the kind of trauma we're talking about is healed by helping a person really generate the capacity to metabolize the events that happen to them. to grow their capacity to think and feel in the context of these feelings that are overwhelming so that their mind can digest it, they can think, they can dream about it, and eventually put it into the unconscious. They'll never not remember what happened to them, but if it can be like other memories and go into the unconscious, then that's treatment.
Well, to what I think of decathexis, I mean, to
Yes.
discharge it, use plain English. If the affect, we don't have to say beta or alpha. We don't have to say decathexis. We can speak very plainly. If it's a discharge, if the emotional investment, if the affective investment, if the energy in that unmetabolized, raw, unprocessed experience is still nagging at somebody, then the relationship itself, the sanctuary of the consulting room, the treatment modality almost doesn't matter. Again, back to the dodo bird verdict. And we're saying we can help you place or evolve space or develop space where it hasn't been before, reflect in a way that you haven't been able to before, help maintain, contain, and maybe dilute the overwhelm, share in it together, blood in the water together, and not be ahead. Listen in a way that you haven't felt safe to listen to it before. Hold your hand alongside of it, but not in a validating way that robs you of your self-preservation, self-determination, and self-actualization, but in a way that helps nurture your ability to develop through and
Yeah.
mourn. I mean, it's
Yeah.
like, I don't know.
I agree
It
with all
seems
that.
clear.
I know we're running up on time, but like one psychodynamic, psychoanalytic idea about helping people with trauma is when you start to create a therapy relationship, and you've got a frame, there's rules about like you meet regularly and the person can kind of say whatever's on their mind. And if they worry that you might have a judgment of them, that can be explored, right? Trust develops, which allows a person to confront topics that they're normally scared to confront. That alone helps with trauma.
Sure.
Okay, so the other thing that I think is important from psychodynamic, psychoanalytic thinking about dealing with trauma is when you really get someone who has trauma to start to open up, and when a person with trauma really opens up to you, you start to feel something as the therapist too. You start to feel them projecting into you, not intentionally, but just as a matter of connecting with them, something overwhelming. They're telling you the details, starting to about what happened to them. You see their body, you see how they're reacting, and you have a big reaction. And I think for many clinicians, that creates anxiety, and that anxiety makes them want a tool. Let me do EMDR. Let me read a manual that tells me what I'm supposed to say here. And that maybe would allow some people to work through the trauma. But I think in the worst cases of trauma that I've seen, what's really required is for the clinician to first be able to take what's being projected into them and they start to feel as countertransference, and to be able to think about it and digest it and start to think in the face of those feelings. And so the patient can start to think in the face of those feelings too. And you have a case where two minds are kind of trying to digest one set of overwhelming feelings together. I know that's metaphorical, but that is really how it works out. That you won't get in an EMDR manual. You won't get that in a set of techniques or interventions. And my worry is in some cases of trauma, you actually kind of get the sense that, oh, we tried these interventions, they didn't work for you. Well, like they used to say in old time analysis, you failed the treatment. And I think that's really unfortunate. I think trauma takes a long time to treat. I think it requires a frame, safety, a therapy relationship. And I think it requires a therapist who can really use their own countertransference to figure out what it is that is really getting in the way of the patient being able to digest or metabolize these overwhelming feelings.
Right. They have to have their walls have to be the clinician's walls of their own vessel have to
Yes.
be strong enough to contain the pressure. I'm thinking again of like chemistry class of a pressure vessel. And they have to be able to not only contain it, but then they have to be able to decipher it. So they have to be able to interpret it at the same time. There's all this pressure of these, highly charged particles, beta elements, we'll support the beyondians today and be able to then metabolize it a little bit to help them process it themselves. You're not doing the work for them, but you're doing it with them. And then in that relationship, you're helping somebody almost kickstart. You're spurring it, like you're truly like a catalyst. I keep thinking of chemistry because you're containing it and you're lowering the activation energy required. God, I'm a nerd for the material to start moving forward, to being mourned, to being processed, and so on. And it ought not be controversial, and yet it seems like it is. I wish we have to wrap up in a minute, but I hope one day we could do this with somebody who does EMDR or does treat complex speech. I could think of a colleague right now in that way. And maybe there is more common ground. I'm always open to that, than
Yeah.
we realize.
My guess would be that just like CBT, there's all sorts of research showing that what really works in CBT is when the same active elements that are present in psychodynamic therapy are when you're really like listening. And my guess is in EMDR or the trauma-informed therapies, some of the clinicians are forming a relationship and they are reflecting on their countertransference. But here's the controversial part. I think a lot of the manualized stuff and the techniques and the interventions and the tapping. Part of what is useful is it helps the therapist manage their own countertransference so they don't get overwhelmed more than
Right.
the patient.
Because not having something to do is incredibly challenging when you feel yourself filling up with that
Yes.
raw affect. And so having something to externalize into, to project into, to displace because your own vessel is full of overwhelm. Yeah, so certainly that's plausible and reasonable and probably common. At the same time, the hope would be like you're saying, is that the relationship is still being built and it's not technique or intervention is not robbing the individuals, the two people in the room from
That's right.
doing the work.
Yeah.
But we don't know. Well, I do have to thank you for coming again. I wish we had more time today, but technical difficulties and responsibilities have gotten in the way once more.
Yeah, technical difficulties. Maybe we'll do trauma part 2.
We'll do a trauma part 2. Yeah. Well, definitely, because we're going to get those strongly worded letters that I won't be able to understand. And so I look forward to it.
Just put my head in the sand for a while next.
Exactly. All right. Good to see you. All right. Thank you again. All right. Bye.
Bye.